The first question actually is for Jack. Are you back online there, Jack? I'm not certain.
Yes, how you going?
Yes, you go. Yeah, you're out on the farm.
Yep.
So I think they've I think that Dylan and Cecilia talked about the impact of how radiation may have on the influence of hormones. And the first question is, at this stage, you're 11 months post radiosurgery. You're probably 2 and a bit years after a couple of transnasal microsurgeries or endoscopic surgeries. And you have said that you had low testosterone previously. Have you had any other issues with your hormones thus far? The rest of the other hormones?
No, I've been very lucky actually since my second surgery. My testosterone came back higher, and then since the radiation, everything else seems to be normal. Thyroid, testosterone, all well above the low levels. So I'm very happy that nothing has been impacted as of yet.
Okay, and Dylan, how often do we test for the hormonal changes after radiosurgery in this situation?
Yeah, we certainly don't develop hormonal deficiencies rapidly. So it's not something that we worry about, to test every month or something like that. Typical follow-ups would be every 6 months. We would do in the initial sort of phase after radiosurgery, and we will actually make the follow-up less frequent as we go along without deficiencies.
Okay, thank you. Another question for you, Dylan, is that with Typroton, you said it's one of the medical managements nowadays that can be used in some instances for Cushing's disease. Do you know what the cost of it is? It actually subsidized on PBS, or is it very expensive at the moment?
It is very expensive. It isn't PBS subsidized. Having said that, we have at St. Vincent's at least a process of which we can apply to access what's called compassionate access through the hospital. Of course, priority for that is given to life-threatening inpatient conditions, and hence we have to make a really good, strong case as to why we would end up on medical therapy. And often the questions that get asked from the committee as to why we're not pursuing other more definitive management. So it really is our only option of getting some sort of subsidy. The cost is something, it will depend on the dosage. So for example, it comes in 250 milligram capsules, and a bottle of 50 will cost something in the order of about $420. So that is very costly because, if you look at a month's supply of the lowest possible dose, which is about 250 milligrams twice daily, you're looking at, at the lowest dose, something in the order of $420 for 25 days. But the dosage can go up to 3 times that, which would make the cost more than $1,000 a month then.
Okay. Another question with regards to medical therapy, Dylan. Why don't we just use medication therapy long term? I mean, why do we want to look at surgery or radiosurgery or adrenalectomies?
Yeah, no, good question. And it all just comes down to the rate of success in achieving remission, and hence other subsequent complications of having untreated pathologically high levels of cortisol that can bring on other mainly metabolic complications such as obesity, diabetes, hypertension, and osteoporosis. So medical therapy will not achieve remission at a rate at which the other modalities can. Medical therapy is not without its own problems. For example, ketoconazole, one of the things, a more affordable drug than metarapone, there's a big worry about liver damage, especially when used in the longer term. And we certainly don't have very good long-term data on using these drugs for decades, and that will always be a concern of ours, especially when we're not achieving the sort of outcomes that we need to as well.
Okay, all right. Cecilia, a question regarding radiosurgery. We have James Lee talking about adrenalectomies, and we've moved from endoscopic surgery to with radiosurgery for pituitary gland. is there any role for radiosurgery to the adrenals as opposed to adrenalectomies?
That's a really good question, actually. So I'll have to preface this by saying that in terms of focused radiation, I'm a brain specialist, but I have colleagues who do the same sort of focused radiation outside the brain, and that's called stereotactic body radiotherapy or stereotactic body radiosurgery. We have done a number of cases of using this focused radiation to the adrenal gland. So initially that was in adrenal metastases from other cancers. But there is some emerging data on using bilateral adrenal stereotactic body radiotherapy for that very situation. Not to steal James's thunder, and as I said, it's not my specific area of specialty, but I think that may be something that we see more of over the coming sort of decade. And I also just wanted to point out, I'm very jealous of Jack's clear skies at the moment. Up here in Sydney, all I've got outside my door is rain.
Yes. All right, thank you for that. Question for James here. Do we always do bilateral adrenalectomies in this situation? Is there any benefit in doing one adrenal gland only?
Yeah, now that's a really good question. So for Cushing's disease, so by definition, the reason for the Cushing syndrome and Cushing's disease is an external stimulus to the adrenal gland, and both adrenal glands are usually equally stimulated. So almost always, because you never say never in medicine, but almost always, to be effective, you do need to do bilateral adrenalectomy. But unilateral, so one-sided adrenal surgery are reserved for those patients who have problems with one adrenal gland. So you can have a tumor within the adrenal gland itself producing cortisol that's got nothing to do with the pituitary, and the other one is completely normal. So that's the more common, in terms of adrenal surgery, that's the more common reason for adrenal surgery for Cushing syndrome. And in those situations, you do just take out the one gland. And in fact, it's the post-operative course is quite different because you don't need replacement therapy. You usually don't need replacement therapy long-term. You might need it short-term, but you don't need it long-term after removal of just one gland due to tumor.
Okay, and that leads on to the second question, which may include both Dylan and James. What daily medication is required if you've had bilateral adrenalectomies? Does the cortisol disappear straight away? Are we replacing this? And maybe, I don't know who wants to go first, maybe Dylan.
Yeah, well, I mean, we would have to start hydrocortisone replacement and fludrocortisone being the other one. And I think that's what James was talking about, saying that there are other hormonal functions of the adrenal gland, and they will have to be replaced almost straight away. And the dosages are adjusted based off both clinical criteria as well as biochemical criteria in order to adjust that for a given individual. And that's daily administration of tablets, essentially.
Okay.
Yeah, that's exactly right, Dylan. So I would just like to add, so in terms of care in that immediate period after the surgery, so I alluded to the fact that doing surgery on one adrenal gland versus two adrenal glands is very different. So in someone who has one adrenal gland removed with a normal adrenal gland on the other side, with the current technique of the keyhole surgery from the back, it's virtually an overnight, sometimes even possible for a day procedure. So it's a very short hospital stay. Whereas if we remove both adrenal glands at the same time, the post-operative care is a lot more complex, definitely a multi-team approach, multidisciplinary team approach. And Dylan also mentioned in his talk that the cortisol level is adjusted due to your stress levels. Having surgery is huge stress. So that stress dose of additional cortisol needs to be given as soon as both glands are removed. And we need to watch that for a few days before we can let the patient go home. And also the other thing to remember is that being the last resort for Cushing's disease, these patients have been affected by high levels of cortisol for a long time. So by the time they come to surgery, their body's already quite tired. They're not very good at fighting off infection. Wound healing might be a little bit poorer than usual with the diabetes as well. And then there's high risk of both bleeding and blood clots. So the care for these patients becomes quite complex and sometimes even challenging in that situation.
A few more questions that we'll try and get through relatively quickly. Cecilia, long-term risk of cancers with radiosurgery to the skull base, the doses you're using, please.
Sure, look, I mean, that's something that I always talk to patients about. I've never had a patient have a cancer after stereotactic radiosurgery. And look, partly that's because the volume that we're treating is really, really small. But having said that, the quote that I usually use is less than 0.1%. And it's something that can happen 10 to 20 years or more down the track.
Okay, perfect. Thank you. Question for Dylan. Any comments on the use of Dosinex or for second-line treatment for control of Cushing's? Has it been effective? Are there any dose-dependent effects? Does the effect reduce over time?
So yes, there's definitely a place for Dosinex. It's often something that we go to if we've exhausted adrenal-based therapy, partly because if you look at the studies looking at the improvement in urinary free cortisol, there's better evidence for adrenal-based therapy. However, sometimes when we're limited with side effects, especially, we will progress to using Dosinex. If there's residual tumor present on MRI that can't be accessed surgically, they're the ones that might probably likely benefit more by the use of pituitary-based therapy. But yes, there aren't big studies that have been done, but we do certainly see the effect wear off over time. So that is a problem.
Okay. Question that has come through regarding, can someone explain Nelson syndrome associated with an adrenalectomy? And maybe I'll go to Dylan again with that one, please.
Yeah, well, yeah, Nelson.
We have 5 minutes. This can go for a long time.
Yeah. So Nelson's is essentially a clinical and radiological diagnosis occurring after commonly bilateral adrenal surgery for Cushing's. Essentially, ACTH levels tend to rise, and the thought is that there isn't enough feedback, although steroids are given externally after adrenalectomy, there isn't enough inhibition that occurs on the ACTH, and at a micro level, there's growth of either the pre-existing tumor to a macroscopic level, and that there can be disinhibited growth that occurs. It's not something that's essentially that will give many issues if it's a small area, but the rising ACTH can cause hyperpigmentation. If the tumor gets big enough, the tumor itself will cause cranial nerve palsies, all the issues that can be associated with an enlarging pituitary tumor, essentially, headaches, visual symptoms, and the like. Radiotherapy seems to have a protective effect in some studies, not all. So having had radiotherapy before, an adrenalectomy in some studies was shown to reduce the occurrence of this. Anyone who had higher sort of ACTH levels following surgery was at more risk, and people who had more severe and rapid onset Cushing's were at more risk. But the actual dosage at which you give the steroids or return the hydrocortisone doesn't seem to have any association with this.
I might ask Cecilia if she's got any comments in it about the radiotherapy and Nelson's.
Thanks for that. Look, also, I guess just to point out as a treatment for Nelson's, so I've actually treated a number of patients with stereotactic radiosurgery who've developed Nelson's, who may not have had radiation as part of their initial treatment. So I guess just remembering that, you know, radiotherapy can have a role in that sort of situation as well.
Okay, great. There's a question from Sylvia Tetlow, who Sylvia's one of our patient support liaison coordinators. She does volunteer with the foundation as well for Cushing's disease. Is there a plan to have a Cushing's disease registry in Australia? Now, I'm going to go to you again, Dylan, then I might have a comment on this as well.
I was hoping you could answer that.
Okay. I guess I will take this. Sylvia, the answer is there's always, disease registries are very important and do have great benefit, particularly with something like Cushing's, where I think we've seen today with all our speakers and Jack's journey that it's complex, okay? If it's really easy, when you've got appendicitis, you take it out, that's the end of the story, that's the treatment to be done, okay? If you've got, when you've got Cushing's, we got to diagnose it correctly, which can take a long time. We have to choose the correct treatment, and the correct treatment is a treatment algorithm. Well, it starts with diagnosis, usually surgery, transnasal surgery, then maybe medical therapy whilst you're looking at radiosurgery, and then we may look at adrenalectomies. And after adrenalectomy, we heard we might actually be using radiosurgery again, okay, for Nelson's. And because each of these steps, the actual success rate is not 100%, it's a very complex thing. And that's where I think a disease registry is a good option. Okay. However, we need a certain entry point and common point of diagnosis. And the problem with a Cushing's registry is that the diagnosis sometimes can be difficult, right? So without having a disease registry, what the foundation is trying to do and trying to push through is these pituitary centers of excellence, which tries to have the highest level of multimodality care, whereby we can actually get the diagnosis as robust as possible with the most effective combination of screening tests. And that's where we are starting with. A disease registry then can come from that if we have multiple pituitary centers of excellence treated in a few large centers. And there's very good evidence that that if we can actually treat someone in high volume pituitary centers, the actual outcomes are better. And you can see most of these, all of our speakers and Jack are treated at high volume centers, which then gives them a great expertise in that region there. Okay. I hope that answers your question slightly, Sylvia. It may not fully, but that's where we're kind of headed for this. And certainly the foundation is trying to push for more of these centers of excellence throughout the actual nation. On that note, we've hit 2:02. I want to thank again all our speakers. Thank you, specifically Jack, to take time out of your day, your sunny day in the farm there. I can see you're still working. I'm really pleased that you are able to work like this with everything that's been going on. To Dylan, Cecilia, and James, thank you very much for your time and expertise, and to all our audience who have been listening in. This webinar has been recorded, collated, and then I'll actually put it through on our website and our YouTube channel. On our website also, which is pituitary.asn.au, we do have multiple information sheets. So if you are looking at some, we have a Cushing disease information sheet that's on there in conjunction, which talks about these in a very sort of 2-page handout. Actually, this is 3 pages, but a lot of these are on there in terms of acromegaly as well, other treatments and things like that. So thank you very much for attending. We will obviously let you know when we're having our next one, and we will see you all next time. Thank you.
Thank you.
Bye-bye.
Bye.